I will talk about visceral and abdominal injuries and their imaging diagnostics. In abuse, abdominal injuries are relatively less common compared to the head injuries and skeletal injuries. Based on cases, in particular, American case studies, percentages go from 0.5 to 11% out of all abuse-related injuries, while up to 16% of abdominal injuries in young children, they are related to abuse. So it's about 2.33 cases per million of children per year under 5, but probably this is an underestimation. So in spite of this low incidence, they are associated with a high percentage of morbidity and mortality, which can come up to 53% of cases. So after brain injuries, these represent the second cause of death. The high mortality is linked in particular to two factors. First of all, the fact that medical care is looked for in delay, so it is an abuse itself, and very often the child is taken to the hospital many hours after trauma. Sometimes trauma is not immediately recognized, and the visceral injuries are severe, so they are associated with a high need for ICU hospitalization and in some cases even surgery, and the treatment chosen is very often a conservative one. If we compare this trauma with accidental trauma, the abdominal injuries are reported in children, abused children at any age. The average age is under 3, while fatal injuries is about 2 years of age. The pathogenetic mechanism includes at least one episode of compression, abrupt direct force that could be punching or kicking, or the fact of launching the child against a rough surface, as we can see in this drawing. But rarely the abuse perpetrator confesses its action, and so we do not know the details of the trauma dynamics, and sometimes they are not compatible with the clinical objectivity or the abilities of the child. So sometimes there is a often a set of excuses, like the child has fallen off from bed, or I squeezed my child while sleeping. So every time that there is a mismatch between the explanation and the injury, so it is legitimate to start investigation for a potential abuse. As for clinical presentation, so non-accidental injuries, so the clinical presentation does not differ from accidental trauma. We can differ and divide traumas into minor and major. Sometimes minor trauma can be moderated. They can include some functional disorders, anemia, loss of weight, and sometimes the clinician can be addressed and can be confused. So the imaging diagnostics, the imaging testing is very important in order to focus on the types of trauma. If we make a distinction between solid organs and hollow viscera, we can say that solid organs injuries are more common, and vice versa, the hollow viscera injuries are much more common in abuse rather than accidental trauma, even up to 50%. And these are the most common injuries, intra-abdominal injuries, even before we use the CT scan. So every time we have a child under 5 with an intestinal or an abdominal injury, we have to suspect physical abuse. Now, I immediately talk about the imaging methods. So the radiologist needs to help the clinician in identifying the most appropriate methods to identify, characterize, and report the traumatic signals. We have to remind that sometimes even minor injuries that can be considered as minors, in reality have a very important forensic implications. The direct abdomen radiography is the first screening that we can carry out on the child, and then ultrasound scan, even for unstable patient, because you can do it even when the patient is in bed. And the CT scan is the most important screening test with IV contrast medium. It is the same scan allows us to see parenchymatous organs, viscera, bones, the digestive tract RX, and the MRI in emergency situations is not so feasible.